Good afternoon, everyone. My name is Andrew Zale, and I work for the Hawaii State Department of Health. And I want to thank you for joining us for this webinar today. We're very excited to hear from Dr. Paul Glassman for his presentation. To start off, I just wanted to go through a few housekeeping rules. If you do have any questions, please input the questions into the chat box. And later on, we will have a moderator review the questions at the end of the presentation so we can answer any of those questions. Also, regarding the Hawaii CE credits, after this presentation, anybody who registered for this presentation will be sent a CE credit for your dental license continuing education credit. So I'm very proud to present Dr. Paul Glassman today. Today, we're pleased to welcome Dr. Paul Glassman, a very special guest from California. He'll be sharing with us his perspective and views on teledentistry in the era of COVID-19 and beyond. We would like to express a special acknowledgement and thanks to Dr. Glassman for his significant contributions to teledentistry practices in Hawaii today. To let you know a little bit about Dr. Glassman, Dr. Glassman is an Associate Dean for Research and Community Engagement at the College of Dental Medicine at California Northstate University in Elk Grove, California, and Professor Emeritus at the University of Pacific School of Dentistry in San Francisco, California. He has served on many national panels, including the Institute of Medicine's Committee on Oral Health Access to Services, which produced the IOM report on improving access to oral health care for vulnerable and underserved populations. Dr. Glassman is also a pioneer and has led the national movement to improve oral health using telehealth connected teams and virtual dental homes. With that said, it's an honor to introduce and welcome Dr. Paul Glassman.
Great, Andrew. Thank you so much for the introduction, and it's a pleasure to be here. I've got my fake Hawaii background showing here, which you can do through Zoom. That's to give me a little bit of a sense that I'm wishing I could actually be there with all of you in person, but because travel is not possible these days, we're doing it this way. I know probably many of you are doing like I am, spending a lot of your time on Zoom calls. So you may be getting a little tired of Zoom, but at least it gets us to be able to interact with each other at a distance and in a time when we really can't get together. So what I'm going to try to do today is to provide some background about this issue of using teledentistry, both now in the era of COVID and then start to look a little bit beyond that. As you see, our attention is turning nationally from how do we handle the emergency situation to what comes next, and lots of different ideas and conversations going on about that. I'm going to start with just a little bit of history of the work that I've been participating in and helping to facilitate and do some training and technical assistance here in Hawaii, which is this Hawaii Virtual Dental Home project. And so this is a project that has resulted from really many years of conversations with the Department of Health here in Hawaii. And then about 4 years ago, we were able to obtain some funding. And so I want to acknowledge the partners in that. So myself, previously at the University of Pacific School of Dentistry, now at California Northstate University, the Hawaii Department of Health. The two participating clinics and clinical providers have been West Hawaii Community Health Center on the Big Island and Hui no Kealopono on Maui. And then the funding for these projects and this demonstration has come from the Hawaii Dental Service Foundation and the HMSA Foundation. So we're very grateful. All of us are grateful to each other for all of the combined effort that it's taken to get this off the ground and to demonstrate that using teledentistry is actually a viable way to provide dental services. A very brief description of the two different projects. So on the Big Island, one that's been going on a little bit longer, started in 2016, working with West Hawaii Community Health Center. They've been having teams go out into the community 2 or 3 days a week with a focus on young children, and working at a number of different Head Start sites, WIC sites, traveling preschool, low-income housing facility, and then they're now proposing to expand to public and charter elementary schools. And what's been happening is what I've been seeing in other parts of the country where you get a project like this going, people talk to each other, and now they're getting lots of phone calls saying, hey, can you do this in our area as well, because there's such a big need, and people are starting to get the idea how effective it is. They're finding that the majority of children that they're seeing in these community sites have actually been able to be kept healthy without needing a trip to a physical dental office. A dentist is involved in the telehealth system, which we'll talk about in a few minutes. But most children actually be able to stay healthy in the community sites, which is a huge boost for being able to keep a population that has trouble getting to dental clinics and offices, keep them healthy. And since this year, this program is operating without grant funding. They are a federally qualified health center, and there's still things going on to try and address the billing arrangements for federally qualified health centers in Hawaii and make it a sustainable program. The other side of the demonstration project is on Maui, and the clinic there is the Hui no Ke Lapono Clinic Community Health Center. Again, 2 to 3 days a week of activities in the community. They've had more of a spectrum of services across the age spectrum with both young children and the elderly, so also working in Head Start and WIC, but they're actually working in 2 elder care facilities, Halemakua Health Services and the Kula Hospital, and thinking about expanding that in the future to public elementary schools. Same thing, finding that the majority of children could be treated at a community site, and the things that they needed could be done in the community site without needing to make a trip to a dental office. Again, the dentist is involved through the telehealth system, but not necessarily have to be physically present with the patient. One of the other unique aspects of the project on Maui is that they've been able to include dental hygiene students in it. So the University of Hawaii Maui College Dental Hygiene Program has had students rotating and getting some firsthand experiences on really a new and expanded role for dental hygienists. They're billing fee-for-service, billing Medicaid and commercial dental insurers, and that's actually already in place. And these projects have been getting, I don't know how many people who are listening now were aware of them, maybe many of you were, but certainly getting a lot of notoriety. This was a meeting on Maui last year. The mayor of Maui standing in the background right in front of Dr. Emi Orikazu, who's receiving the award there, and the commemoration of this project as being a significant contributor to the health of the people on the island of Maui. So that's a little bit about what's been going on in Hawaii, this demonstration project that's been taking place. Let me just switch now to the national scene. Just one sort of data slide from the American Dental Association, which is one that they tracking people's utilization of dental care. This is broken down by age group. And what this shows is that the majority of people in the United States are actually not getting dental care. This is utilization by age. The orange line is children, so they're the highest utilizers of dental care. But even among children, well, in 2015, it was less than half. It's bumped up and a little bit over 50% now, but still, it's only around half the children are having, even in this data, which is a very low bar. It's an annual dental visit. So it doesn't mean all these children even got complete dental care. And even by that very low bar, only around half the children are even having any kind of semblance of regular dental care. Less than that for seniors, and only about a third of working age adults. So we have a oral health system in the United States that is not reaching most of the people in the country. Some estimates around 200 million people not getting any kind of semblance of regular dental care. Some data I'm borrowing from a slide from Dr. Tseu, which is a little bit old now, but certainly there's no numbers here, so that the idea is still relevant, which is that Hawaii's children have among the highest prevalence of tooth decay in the United States. There's huge disparities among uninsured and low-income people and elderly and native Hawaiian and Pacific Islanders, and that oral healthcare system isn't adequately addressing the needs of much of the population, particularly those vulnerable and underserved people. So that's sort of it for sort of data and why people are thinking about we got to do something differently. Let me switch now to what is it that we can think about doing differently. Well, one thing would be that people are thinking about is kind of a three-part effort, which people are saying this is really where we need to go to get to create a different kind of healthcare system and different kinds of results in our country. And it involves these three kinds of efforts. So on the bottom left is measurement and payment systems. And there's increasing work now, lots of different people in the oral health industry working on how do we create a measurement and payment system that does a better job of rewarding providers for producing a healthy population. Some people call this a movement from paying for volume, where you just get paid for doing a lot of stuff, to value, where the payment is more closely tied to producing a healthy population. That's not really much in evidence now, but again, there's lots of people in the oral health industry that are working on how to do that, including the American Dental Association and something called the Dental Quality Alliance. The second major aspect, the top part of that thing, is the dental delivery system. So with the data I just showed you, where we know that most people are not getting regular dental care, so how do we get to the people who are not getting regular dental care? How do we actually become in contact with them so that we have some hope of doing something? Because you're not going to do anything for someone that you're not in contact with in any way. So how do we get in contact? How do we have delivery systems that actually can contact people? And we'll talk more about that, particularly with the emphasis on using teledentistry to do that. And then the third part of this three-part diagram is prevention and behavior science. And I'm just going to drill down a little bit more on that one, not too far, but just really to say that something maybe many of the people listening here have heard about is that we have some new tools in our toolbox now that we just did not have many years ago, certainly not when I was in dental school. We have agents for remineralizing teeth, fluoride varnish, and caries arresting medication, silver diamine fluoride, and other things, and the ability to seal caries, the knowledge you don't have to remove all the decay from a tooth to be able to seal the caries in place. All these things were not in evidence when I was in dental school, for sure. And if you took it at that top left diagram there, now the one with the I can even point at it here, the one with the brown spots on these teeth. Certainly when I was in school, the only thing that you could do about that was to get the dental drill and drill out those areas and be able to put a conventional filling. Well, it's not true anymore. Now there's all kinds of things that you can do to repair the demineralization, or even repair it once it's turned into frank decay, or stop the progression without needing a dental drill, and therefore without needing a dental office or even needing a dentist to be in. Dentists might be determining treatment or determining a plan, but not having to be physically with the child. So it opens up a whole different way of thinking about care. It opens up the possibility of doing care in communities with the dentist having a role as directing the services, but not having to be physically present. So that's sort of the prevention part of prevention and behavior sciences. And then the better understanding about behavior science is, I think most people realize that the number one thing that has people either be healthy or not is what they're doing on a daily basis in terms of their own, what I call mouth healthy habits. And so we know it's not easy to get people to adopt mouth healthy habits, but we do now know some things about what causes people to adopt better habits. We're talking mostly about mouth cleaning and diet, what you eat and how you clean your mouth every day. What we do know is that people are much more likely to adopt mouth healthy habits if they have messages that are delivered by multiple people, particularly if there's trusted members of their own community who are talking to them about good things to do. We know people are much more likely to adopt new habits if they're presented with some kind of small incremental change, and then someone's there a couple of days later to say, hey, how did that small thing you were going to try go? Did it go okay? Yeah, it went well. Okay, great. Why don't you try just doing, extending it a little bit further? So that kind of small incremental change is much more likely to produce long-lasting behavior change than someone giving them a whole list of things to do, and then people just generally become overwhelmed and don't do anything. And so the whole idea of incremental behavior change, ongoing reinforcement, coaching, peer support, all of those are things that are very difficult to do in a dental office situation where you may not be seeing the person at all, or you may be seeing them mostly for just an occasional emergency visit, or even the 6-month recall. There's a long time in between those 6-month recalls. And so having a partnership with a community organization that's actually in touch with the individual or a child with their parents on a much more regular basis, you have a much better chance of having people adopt mouth healthy habits than you do having dentists and hygienists in a dental office trying to give what I call the speech to get people to change their behaviors. Much less likely to be effective that way. And that all leads to the thing we'll talk about in a few minutes about partnerships with the community. All right, so let's switch to the third part of the diagram now, which is delivery systems, and we'll focus now on teledentistry as a means of getting to people who are not having regular dental care. So teledentistry can mean a lot of different things. There's a lot of ways that these technologies can be used. Dentist-to-dentist interactions, dentist sharing records. That's not actually all that new. Real-time video consultation, and that's becoming actually much more important in the COVID era now, and we'll talk more about that. Store and forward record review, where it might be a dental hygienist and in a school, like it's happening on Maui and in the Big Island now, collecting X-rays and photographs and sharing that with the dentist who can review the records and make a diagnosis and treatment plan. You start to see now more patient-to-dentist interactions where patients are sending the dentist a photograph of their mouth for some kind of advice or support about that. I don't have time today to go into it, but there's even people who are developing real-time video surgical support. So that sounds like science fiction, but it's not that far in the future before we're going to start to see implementations of that. The word mHealth data collection refers to just doing some of the same kinds of things, only using a smartphone or one of the things that we all carry around our hip these days. And finally, we'll spend more of our time now talking about the idea of using teledentistry for telehealth connected teams. One more slide about what teledentistry is or how people are using it these days, and that's sort of a categorization I've come up with, sort of 4 categories of how people are using teledentistry. So on the left is maybe at the lowest level is some kind of just advice or referral system. This is the patient who takes a picture of their mouth because they chipped their tooth, and the dentist looks at the picture and says, I think it's going to be fine, make an appointment when you can. Right now, it's probably not that easy to make an appointment, but make an appointment when you can. Or, boy, that's a really big problem, the pulp is exposed and we better get you in as soon as we can. So that would be sort of a low level of use of technology to get some quick advice. Maybe there's a video conference, maybe not even a video conference, maybe just some still photos, or maybe not even that. Above that, we have a lot of companies these days that are beginning to do what are called call centers, or what I'm referring to as call centers. And that might be something where a patient realizes there's this place they can get advice. They call up, get an appointment with a dentist who's at the other end. The dentist talks to them, maybe over a real-time video conference, maybe takes the camera and puts it in the person's mouth and takes a look at something, and then makes a referral. So that's sort of the call center, is some kind of evaluation and referral. Then we have companies that are doing what I'm referring to here as more limited on-site care. Limited on-site care meaning they might have a team that goes out into the community, something like our virtual dental home system, only maybe they go into a business somewhere, and they do collect some diagnostic records, which a dentist reviews. But then when someone needs to see a dentist, they don't have a dentist to refer them to. They just refer them to another dentist. So it's kind of limited front-end care, but the end result is a referral to a dentist. And then finally, you have a full-service system of care with all of the components, video conferencing and cloud-based software platform and a community team and an integrated network, where you actually have the dentist who's reviewing the records and is making a diagnosis and treatment plan. That's the same dentist who would see the patient if they need something to be done by the dentist in a dentist's office. So you have a really full continuity of care where the dentist is both reviewing the records, making the diagnosis, and then also available to do the treatment. And there's no breakup of the care where you're starting diagnosis and referring them somewhere else should they need a different part of the treatment. So that's the principle that we've been working on for really this full service system of care for a long time. And you heard a little bit about what's happening in Hawaii. So I'll just show a few slides about kind of how it works. So this one is just the title side, the virtual dental home. And the name virtual dental home comes from the idea that we're reproducing all of the concepts that are part of what a lot of people are referring to as the health home system. You hear medical home and health homes, and now the dental home as it applies to dentistry. And this is the idea of making sure people don't get lost in a complicated system. They get to where they need to go when they need to go there. They get advice about how to manage their own health. And we're doing all that through what we're referring to as a geographically distributed telehealth connected team. So different people in different places, but they're working together to produce a full service system of care. So this is a hygienist with their assistant and some portable equipment. So they can be all fits in the car in one place one day, a different place another day. They're collecting a full set of digital dental records, including x-rays. For those of you who are not dental professionals in the audience, that's not a hair dryer in her hand. That's actually a miniaturized x-ray machine. So they're collecting dental x-rays, going into a little laptop in the back there. They're collecting photographs. You can see the picture of the tooth in the back. All of this produces a full electronic health record. And in this diagram, which I won't go through all the details of, but the community site is where they're actually collecting the records, and then it all goes up in some kind of cloud-based server where there's a dentist who's not on site can review the records and then decide what happens next. And the dentist can decide, is this someone who needs to have care by a dentist in a dental office because their disease is advanced enough that it really can't be handled by the hygienist, or can it be handled by the hygienist on site, who can then do prevention and early intervention services, case management, integrating dental care into the educational and social and general health services where they're working. So when we first started doing this system, we started with a demonstration in California across 13 different sites. And what we found was we're beginning to collect enough data to see we're duplicating the same kind of, or very similar results here in Hawaii. That number one, you could reach people who are not typically getting dental care and get to them, particularly if you're dealing with children, get to them early, actually emphasize prevention, lower costs. Most children in particular could be kept healthy, but even a lot of adults can be as well. But with children, about 2/3 or now even more children can have everything they need done in the community site by a hygienist with the right level of duties. This continuous presence where they're there all year long, not 5 days a week, it might be only 1 day every other week, but they're there all year long, really raises everyone's awareness about oral health. So people start to think about oral health. We find teachers are starting to visit their own dentists more than they were before, because it's in the air now, in the atmosphere. And then of course it integrates the community organization and the dentist. So the dentist you're not doing school-based care over here and then dental care is over there. It's all kind of one system that are linked together. This started really in California, and then shortly after that, Hawaii and a couple other states. And now in 2020, we're seeing this really all over the country now. There's no question that this is going to be an important part of dental care in the future. And my prediction has been for a long time that about, I don't know if it's going to be 5 years, 10 years, or 20 years from now, but at some point you can ask people, do you use teledentistry as a part of how you deliver dental care? And the answer is going to be, well, of course we do that. Why would we not do that? We're not there yet in terms of people's understanding of the value of it, but we're clearly moving in that direction. So I think we can summarize this part of the talk by just saying we're moving towards a system now where we can really think about community engaged oral health systems. Dental care no longer has to be confined to the four walls of an office. A dental practice can be the high-cost surgical suite, which is the office, but also have a part of the practice which is in the community, where you have part of the team reaching people who would not normally be part of a dental care system. And again, the golden rings in all this is a combination of incentive systems, reimbursement systems, delivery systems, and then prevention and behavior science. But now we have a little bit of a different focus because we're in a world of COVID-19. And so now we have a new challenge currently on maintaining and services and contact with patients at a time when we really have to pay a lot more attention to physical distancing. And so we're facing a situation now where we have people that are cut off from dental care. Practices are trying to figure out how do they provide only emergency services, how do they stay in contact with people. And so there's a real need to establish communication and provide triage and consult and limit the in-person services as much as possible. And then also a part of that is there's a real need now to have a dental care system that can effectively treat dental concerns so that people with dental concerns don't end up in other parts of the healthcare system. Particularly, you don't want people with dental problems going over into hospital emergency rooms. So there's a couple ways that this is being done. A lot of people are pretty clever in figuring out things to do. I'm differentiating this now into what I call the optimized systems, which are pretty complete teledentistry systems that sort of put all the components together, versus people now a lot of dental providers are kind of using some tool that they found somewhere. So maybe they're having patients email them photographs, or they're getting some off-the-shelf using Zoom for a video conference and getting a different system for payment and a different system for patient to give consent to the video conference. And the disadvantage of those things that they're all separate. And then at the end, if you're going to have a complete record of what you're doing, which you have to have, there's no relaxation of that requirement. You have to start copying and pasting stuff from a bunch of different places. So I'm going to focus the rest of the description of what I think people can be doing to stay in touch with patients now on the optimized system. So this would be a system where you have an ability to notify patients, come up with a plan for how you're going to deal with them, provide advice, consultation, and triage, try to keep the in-person visits to a minimum, and then have all that stuff in a secure electronic record system where you have a complete record. So this flow diagram here, I'm going to just walk through it a little bit to give you a sense of how a system like that can work. So the orange parts are things that the office would do, the blue parts are things that the patient would do. So first of all, there'd be a process of notifying patients that you have such a system. If you're a dental clinic or dental office, you notify patients such a system is available. So the patient would register, get set up in some kind of portal. Some patients will just do that themselves. Sometimes the patient calls the office and they might be directed to sign up in the portal. Sometimes the office might contact the patient and let them know, or in either case, help the patient or actually set them in the portal themselves if the patient's not capable of doing it. But one way or the other, the patient gets enrolled in a portal. The patient then has the ability to upload photographs, other kinds of records, maybe select the kind of appointment they want based on the urgency of how they perceive their situation, provide payment. They can actually pay for services over this system, maybe fill out forms like a consent for telehealth, and then schedule an appointment for a real-time conference with the dentist. And if you have a system like this, the good ones now are their office is notified when the patient enters some information so they can check and make sure that the information was done completely. And then it would lead to a real-time synchronous video conference with the dentist, or maybe someone else in the office. Maybe it might be the hygienist might have a role. And over that synchronous video conference, you can provide advice, perhaps a prescription, maybe even sort of a drive-by dispensing, sort of the drop-off, dispensing of some kind of medication or high-dose fluoride toothpaste or something like that, or a prescription to a pharmacy. Maybe the dentist is going to say, I want to just keep an eye on that situation. Can we schedule another video conference in 2 days from now? We'll just take a look and make sure it's healing okay. So there could be advice, prescriptions, follow-up appointments, or they might use that video conference to plan for an in-person visit. But the point would be that there'd be a record of all these things that happen inside this system. That's sort of the ideal way to do it. So now let's look at this in terms of a workflow and what that would look like, starting from the patient. So if you're a patient and you knew your provider had a system like that, so first of all, you'd be notified that such a system exists. You would get registered inside this patient portal. You sort of choose what your level of response you're asking for, depending on how urgent you think your situation is. Enter what kind of payment or insurance information or whatever other information you have. Fill out forms, including consent for the video conference. Maybe if you're capable, upload some photographs of your mouth if that was relevant, or some old records you had, or anything else that you might want to have the dentist be available for. And then you'd schedule an appointment with an online scheduler based on the kind of appointment that you want to have. Let's look at that from the provider side. So from the provider side, the dentist is, or the office personnel are notified that the patient has registered and uploaded some information, and maybe they made an appointment. They can maybe respond by some kind of messaging system about whether the patient filled out all the forms correctly or not, if they need more information. And then there's a video conference, at which time they can provide advice and consultation and triage, all the things we talked about before, maybe a prescription, maybe a follow-up appointment, or maybe they decide this person really needs to come in for an in-person visit. I do want to just say that the American Dental Association, if you haven't looked at their website, their COVID website, has a whole array of tools there, definitions about what's an emergency, flow diagrams about how to conduct a visit, how to screening patients for potential for COVID disease. I'm not going to list all the things they have available, but I urge you to check out their site for lots of resources they have. All right, so now you've decided the person does need an in-person visit. So the provider has the ability in an optimized system like this to get the appointment set up. And here's the key thing. You want to try and make the in-person visit as short as possible. So you can use the telehealth system if you have one that's set up like an optimal one is, to provide consent, signatures on consent forms, explanation of what's going to happen, instructions, maybe preoperative and postoperative instructions. So you don't do any of that stuff when they come in for the visit. There's no sitting in the waiting room. There's no talking. There's no everyone touching the same pen to fill out papers. All that stuff's done through the telehealth system. So now during the in-person visit, maybe the person just actually waits outside until you're ready to see them. You text or call them and say, come on in now. And they don't sit in the waiting room. They just walk right into the operatory. Again, all the paperwork, explanations, signatures, that's all done. Sit in the chair and you just do what has to be done. A very short in and out visit. And then any follow-up also takes place during the teledentistry system. So, you think about the advantages of a system like that to the patient. It's really a one-stop secure access to a provider. The provider, of course, has the ability to maintain contact with patients. A lot of this stuff, and Dr. Sayre is going to talk about it in a few minutes, is billable in today's environment. So you're actually generating revenue for the practice. You can plan for in-person visits, and then you end up with a complete record of everything that happened. And of course, as I said earlier, for the healthcare system, this keeps people out of emergency rooms and other aspects of the healthcare system for dental issues. So, you know, an optimized system like the one I've been describing might have all this stuff in it. You might be able to have a place for people to register and enter information and messaging and fill out forms and schedule their appointments and have live video and consent and explanations and information and all into one integrated record. The American Dental Association has just published actually a few days ago a guide to working an interim guidance toolkit. But it doesn't really address the kind of things we just talked about. So this would be something I'd urge you to get a look at this, but also keep in mind using teledentistry to be able to optimize your workflows. So just in summary for all that stuff, now we're talking about what you can do now in the COVID environment, but start to think about having a system like this as not just something that you're going to use right now to be able to deal with people during a time of physical distancing. Start to think about what the world's going to look like as we emerge from the COVID era. And I was just doing a webinar with a panel of people a couple of days ago, a national webinar, which we had, I think, more than 3,000 people attending it. So a lot of interest in sort of the predictions of where we're going. And the major prediction is we're not going to go back to life as it was before. That for many reasons, one of them being dental care is going to be more expensive than it used to be. There's going to be at least some increase for personal protective equipment. So just the cost of PPE. Our infection control guidelines have not included changing gowns every time we walk from one room to another. Well, we may have to be doing that in the future, and maybe even having some kind of airflow change systems and walling off operatories so one air from one operatory doesn't get into the next one. And so no one knows exactly what that's going to be like, what kind of requirements are going to be in place, but it's pretty clear that they're going to be more than they used to be. And it's pretty clear that dental care is going to get more complicated and expensive. So if you think about a world where dental care is more complicated and expensive because of that, it really leads you to the discussion about, well, how do we deal with that kind of world? And so one of the things that this is a sort of a diagram I bottom is sort of a crude picture of a building, which is just to symbolize the dental office. You know, you might end up in having an office where you maybe have parts of it have a pretty highly modified operatory where you've built in, you know, negative pressure airflow and really walled off the airflow from that operatory to get into other ones. And that would be the place that now has the highest level of protection and the place where you're going to do the most aerosol producing and more complicated procedures. That doesn't have to necessarily be the whole office, but you might have a part of your office that looks like that. You might have another part of your office, which is one in which you have more minimally modified operatories where you have set up for non-aerosolizing, producing more minimally invasive procedures with a moderate level of exposure. And so that really does raise the issue to a level it never really was before of, are there some things you can do with more minimal interventions? Can you use minimally invasive dentistry with medical managements and fluoride varnish and silver-diamine fluoride and interim therapeutic restorations with no drilling to be able to treat a lot of disease that used to be sort of automatically funneled into more conventional restorations with aerosol-producing procedures? There's no doubt in my mind that there's going to be a shift towards a lot of people wanting to know more about and using more minimally invasive procedures. And then on top of the office here, this is a picture of, it's the cloud. You know, this is the, it's not a dark cloud, it's actually a bright cloud because it's the adjunct to dental practice, which now includes office outside of the office and using teledentistry, not just during the COVID emergency, but on an ongoing basis to be able to provide maybe pre and post-operative visit care. So even if you're not doing what the virtual dental home system is doing, where you're having hygienists out in the schools, even if you're just using it for your office practice, there's a number of patients that come into every office, probably some every day, where they're doing just really more sort of talking and a quick look in the mouth. And maybe you can do some of those over the telehealth system so they don't even come into the office. You don't spend, you know, $50 worth of PPE to prepare the chair to have a conversation with a patient. Or at least to make the appointments make the appointments shorter, so stuff can be done outside, and getting consent and paperwork and so much use of the waiting room can really be modified by having a whole teledentistry arm to the office. And of course, there's always the possibility of extending that out to care outside of the office, where you're actually using part of your team to reach people in businesses and schools and Head Start centers and nursing homes and all kinds of places. So my prediction is going to be a huge increase. The COVID era has sort of shined the spotlight on teledentistry, and a lot of people in the oral health industry are realizing it's not just a tool for the COVID emergency, but it's going to be a valuable tool going forward. All right, so now we're just going to shift the conversation and take just a couple minutes about billing issues before we open it up to questions. This is picture here of a chart of a document that the American Dental Association has on coding and billing. They're updating it very frequently, and a part of it is a listing of all the major commercial carriers and what their policies are about telehealth. So if you want to know what a particular commercial carrier that your patient might have, this would be a good place to look for some of the latest information. But finally, I'm going to turn it back to Dr. Tse to talk about sort of what's going on with billing regulations in Hawaii about the use of teledentistry. So Andrew, will go back over to you. I think hopefully Dr. Tse is taking himself off of mute. There we go.
Perfect. Well, thank you, Dr. Glassman. I appreciate all that useful information about teledentistry and how it's being applied to Hawaii and the nation, especially in this time of COVID. What I would like to do is briefly kind of give you a general overview of the teledentistry billing environment that we have today. When I look at the billing environment for teledentistry, I kind of take a look at it into two areas. One is pre-COVID teledentistry reimbursements and post-COVID teledentistry reimbursements. So when we look at before COVID and the situation we're in with this pandemic, many of the teledentistry procedures were reimbursed via telehealth connected teams and the virtual dental home, which Dr. Glassman talked about. So when we look at it, the teledentistry billing procedure codes would be related to the clinical oral examinations or evaluations, radiographic interpretations, and also photographs or some insurance. So when we look at the reimbursable teledentistry procedures for the virtual dental home, Hawaii Medicaid at this time would cover examinations, radiographic interpretation, but they would not cover photographic images. For the Medicaid program, for the fee-for-service side of the providers, the billing for that is very clean and clear that, we are able to submit claims for those procedures. For the FQHCs or the PPS programs at this time, even though they have it administratively and they're allowed to be billed, there are certain clarifications that need to be actually addressed in order for the billing to actually go through at this time. So we are working with that with the FQHCs and MedQuest at this time. Regarding the commercial insurers, HDS, HMSA would also be covering teledentistry related procedures pre-COVID at this time. We also have the mainland commercial insurance that would also cover that also. If you look at the difference right now for the post-COVID environment, the things that we are looking changes is actually clinical evaluation for triage, such as D0140, is actually being covered by our Hawaii dental insurance, HDS and HMSA at this time. And for both these insurance companies, they are accepting video conferencing and also telephonic communications. At this time, the Hawaii Medicaid program has not addressed or made any changes regarding interim coverage for D0140. As we look forward and what we learn from this COVID environment is hopefully people realize the potential regarding teledentistry and all of the advantages that Dr. Glassman talked about, looking at maybe not only covering triage emergencies, look at things such as post-op examinations, consulting, and looking at actually having the patient fill out many of the consent forms, instructions, or health instructions that can be used through teledentistry. So we can use our time more efficiently and actually access the patient's time more efficiently also. So I guess I'll go back to Dr. Glassman at this time.
So I think that's the end of the presentation part. So I think actually Nicole is going to be leading us through questions and answers. Hopefully people have been putting in some questions in the question box. And I'm going to stop sharing the stream now, and we will be able to answer questions that you have. So Nicole, back over to you to ask us whatever questions you want or things that have come in.
Excellent. Thank you, Dr. Glassman. Thank you, Andrew. There are a couple questions that have come through, so I'm just going to read one of them. Is there any data or research that shows that virtual dental homes reduce the use of PPE or certain types of PPE?
Well, let me see if I understand the question. Does the virtual dental home reduce the need for a PPE? Let me just change that question just slightly. I think what the way to ask that would be, what's going to happen when we go back to past the lockdown that we're in right now? And so, my best guess, although nobody knows exactly what the requirements are going to be, is that we will have increased requirements compared to what we used to. So even doing, say, what we have been doing so far in the virtual dental home system with, say, a dental hygienist in the school, it might be that they're going to need to change gowns between patients where they didn't used to do that before. And if that happens, then of course they're going to have to have that expense for probably a bunch of portable gowns, of disposable gowns, rather than just one that they wear all day long, unless they take 10 of them with them and then send them all to laundry afterwards. So there will probably be some increased expenses. I think the thing that we can think about in terms of the cost of doing care in an environment like a school compared to an office is that it's much less costly for lots of reasons. It's less costly just because there's less people around and less salaries, and you're not paying rent in those kind of locations, and they're not doing aerosolizing procedures. So in the past, maybe they have been using an ultrasonic cleaner, but they probably would stop doing that. And so if you're using non-aerosolizing procedures, then the only other cost is maybe some increase for PPE. But I think that we're going to find still a lot less costly to do things in that environment compared to doing them in a dental office, no matter whether you're using aerosols or not. And you're not using aerosols in the community site. You can certainly arrange it that way.
Great, thank you. Next question. Do you have any statistics that show an increased access to care with virtual dentistry based on decreasing the barrier to transportation for patients?
I'm not sure we can specifically call out transportation as an issue, but what we do know is that in many, and I should say that the virtual dental home system now is being used in, well, I've even lost track. I'm guessing it's 10 different states now, and probably hundreds of individual clinics doing it. So because we started out in a small implementation in California, and then Hawaii, and then Colorado and Oregon, and so there's lots of places using around the country. And uniformly, what they're finding is that the large percentage of patients who are being seen in those systems were people who are not getting dental care before. They just had many children who were, part way or even much of the way through elementary school had never seen a dentist before. So it's clear that they're able to reach people who are not getting dental care and get them into a system of care. Now, the question, I guess, would be, why were they not getting dental care before? I'm not sure we can exactly say that it had to do with transportation. Oh, that's obviously one of the factors, but it's transportation. It's the hours that dental offices are open compared to when parents have to take time off of work to bring children in. There's language barriers. There's cultural issues. There's all kinds of things. So clearly bringing care to where these children are is a very important way of breaking down those barriers. And I would have to only just guess that transportation is probably one of the issues, but certainly not the only one that's addressed by bringing care to where children are.
Hi, Dr. Glassman. With the Westway Community Health Center and the Big Island, a lot of times with the geographic dispersion of a lot of the patient, that has helped a lot with regarding transportation, so patients and children don't have to travel so far. But I think the other issue that Dr. Glass mentioned also, there are so many other barriers regarding time. Parents have to take off work and finances in order to take their children to the doctor. So many times regarding teledentistry and the virtual dental home, it may not just be transportational barriers. It could be financial, time, just accessing the dentist, where a dentist could be just very close by.
Great, thank you. Next question. Are patients able to take photographs of sufficient quality to use in diagnosis?
Well, of course, that depends on the patient. So some people are better photographers of their mouth than others are. It certainly helps if you can have, it's really hard to take a picture of your own mouth with a cell phone. So some people can have someone else in their family take the picture. If they're using good lighting and good retraction, they get better pictures. So it's obviously really variable in terms of the quality of the picture that you're going to get. I would say that I would not call it diagnosis. The D0140 is a limited problem-focused evaluation. That's the term. That's the code definition for that. Because I think particularly if you're going to try to say, you might make a diagnosis of that particular problem. The person has a tooth chip, and your diagnosis is that they have a tooth chip. I guess that's okay. But to say that they're healthy or not without radiographs and without a full set of records, I would call it more an evaluation, a problem-focused evaluation at that stage when you're looking at a patient-generated photograph. So the answer is that there's a lot of variation in terms of what patients are able to do, and the dentist really has to use their judgment when they look at something to decide, do they have enough information to be able to make a determination of what they can do with that information or not? And sometimes the answer might be they don't, and the problem sounds serious enough, they're going to have the patient come into the office. Sometimes they might say, that's a pretty good picture, and I think I got a good idea what's going on there. I think I'm going to do X, Y, or Z, a prescription, or just reassure you that everything's okay. So it's a dentist judgment and lots of variation in the quality of images that are being received.
Thank you. We've received a couple questions for recommendations on software or video conferencing mediums. One individual said they use Doxy.me currently. Are there any suggestions that you have for best practice in software and in video conferencing?
Yeah, I need to have a disclaimer here that I do a lot of consulting as a part of my life these days, and several of the companies that I'm going to mention now, I have consulting arrangements with, so I don't get paid for consulting, but at least I am giving them advice, so I just have to give you that disclaimer. So I think, when you use something like Doxy.me is a video conference system with, they advertise it being HIPAA compliant and secure. If you're looking for a system that's really more full-featured, that has all of the things that we talked about before, to go from collecting records to a patient portal, to getting signatures on documents, to being able to capture a full record of everything that happened. The more full-featured systems that are optimized for teledentistry, I'd say, are the one from Mouthwash called Teledent, and the one from Virtual Dental Care called Teledentix. The Teledentix is probably the one that's a little bit more optimized for the teledentistry environment that we're talking about now. So you can check out those two companies and look at their offerings. But there's no single way to do this. But I think what I said at the beginning, I appreciate the question, because I think it does look at the idea of thinking about this as a long-term issue. It's not just a couple more months till we get through the COVID crisis. I think that starting to think about having a really full-featured and robust teledentistry arm of the practice is really a wise way to think about moving into the next phase of all of our lives.
Great, thank you. Next question is regarding HMSA and HDS. Does using teledentistry for HMSA and HDS take away from the normal in-office benefits, say an exam?
I think the question was about, I thought the question when you started was about take away from people going to dental offices. I'm not sure that the question was about, did it take away from benefits? Is that what the question is?
I think this might be more of a coding question.
Okay, got it. Yeah. All right. So I think I understand. So yeah, I think I'm going to interpret the question as meaning if someone saw a hygienist in the community, and then they did whatever, and then they go to a dental office, does the dental office lose the ability to bill for the x-rays or the exam or whatever happened? And that could happen in some situations, but it's not what's happening in the environment we have now. Remember, I talked a little earlier about more kind of a limited on-site care, where you have companies, I don't think they're doing it in Hawaii, but in a number of other states, where there are companies that are going into an office or a school, and they're collecting records, and they have a dentist who reviews them and makes an exam, and then they send the patient to a different dentist. Well, in that case, I'd say yes, that other dentist they sent the patient to then loses the ability to bill for the exam or x-rays, because those have already been done. But that's not the way that the demonstration projects in the virtual dental home system works. The way it's working here in Hawaii is that it's all one team. So the hygienist that goes in, like on Maui, the hygienist that for HNKUP, that's an employee of HNKUP, they go there, they collect the records. The HNKUP dentist reviews the records, does the diagnosis and treatment plans. So the clinic is billing for the examination, the x-rays, the hygienist's time, the cleanings, the sealants that they're doing. So it's all considered in one practice. And so if you do it that way, then there's no concern about somebody billed for something over here, and now I got to do it over there, and now you're going to have duplicate billing, which is why I'm not crazy about the systems where they do only part of it and refer people somewhere else. I think it's much better to be contained within one practice where everyone's linked together. And one of the reasons is precisely the reason that was addressed in this question.
Thank you. Next question. What is the liability exposure when using teledentistry on emergency patients or patients not of record?
Yeah, I think the way to think about that is that this comes up a lot. So the way to think about that is that, first of all, I think that every patient you interact with is a patient of record. And the reason I say that is that it's an obligation. The word patient of record is kind of an ambiguous term. It doesn't have an exact definition, but every patient that a healthcare professional interacts with, you are obligated to have a record of that interaction. If you have a record of the interaction, they are a patient of record. So that anybody that you've provided any professional services with or for, you have a record, they're a patient of record, and you're obligated to do things up to a standard of care and to provide services for them. It doesn't mean you necessarily have to do other things for them later on. You might only have one interaction with them. I mean, that happens in dental offices. People come in for an emergency visit and then they never come back again. But you do have some obligation, at least to suggest to them that they need ongoing care and to document that. So, and in terms of the liability for what you actually did, it's still anything that's within the standard of care. You have, I think I alluded to it earlier, you get some information from the patient. If you're a dentist or a hygienist, you're making your best judgment about, do I have enough information to decide what to do? Can I safely feel like I can tell them to do this and things are going to be okay? Or really, I just have no idea what's going on because the records are so inadequate and I really can't tell. And if you're in the first situation where you think you have a pretty good idea what's going on and you can give them some advice or suggest something, then I think you're totally fine you're well within the standard of care. If you don't have any idea what's going on, then you would be remiss to give them some advice based on a lack of information. That would be the one where you'd have to say something else. I need to get some more records or take a different picture, or maybe we do need to see this one. You do need to come in. So I think if you're just thinking about operating within what would be the normal standard of care, the amount of information you need, that you're going to be well within operating the standard of care. In terms of maybe buried in there was sort of liability might be what malpractice coverage. We've talked to malpractice carriers in lots of states. I can't say I've talked to every malpractice carrier in the country, but and generally the answer is that if you're doing something that you're allowed to do within your license, then you're covered by your malpractice insurance. So as long as you're doing something that you're allowed to do and you're doing it within the standard of care. So really it's a matter of judgment and making sure you're doing things that a reasonable dentist would say you did the reasonable thing for that patient, and then you're going to be fine.
And the other important point is making sure that when we are triaging patients doing video conferencing or even through the phone, is making sure that there's sufficient and proper documentation regarding that, documenting everything that was done. When we look at the Hawaii Dental Practice Act, it does not specify teledentistry can be done, but based upon the Dental Practice Act, there are a lot of teledentistry procedures that can be. So the other thing that we have to look at is making sure that we get informed consent and informing the patient that, we're doing these consultings through teledentistry, and making sure we get consent and document it also to reduce any kind of liability.
Yeah, I think it's a good point. I just want to add something to what Dr. Sayo just said, which is that the purpose of this webinar today was just sort of raise people's awareness about teledentistry, how it's being used now, how it might be an important tool for the future. But if there are providers of dental care in Hawaii who want to understand more about the nuances and the operational details of how do you actually implement a teledentistry system, there's a number of things to need to think about. I mean, Dr. Sayo just mentioned, having a specific consent with some language about teledentistry. So if the coalition wants to organize some additional webinars where we can talk more about operational issues, we can certainly dive down into a greater level of detail at some point.
Great, thank you. And the last question that I have is, somebody had indicated that they were using FaceTime to triage before patients came into the office. And is that considered an exam via teledentistry? And if so, what type of records should be kept and submitted for insurance companies?
Yeah, I'm going to give a response which is similar to the one I gave a few minutes ago, which is I think you have to think about what's the difference between an examination and a problem-focused evaluation. So those are different things in the CDT codes, the ADA CDT codes of different definitions. So typically an examination, either a comprehensive examination or a periodic exam, would be one where the dentist has gotten enough sort of full set of records to be able to say that they can make a definitive statement, diagnosis, and treatment plan for the patient. Often that involves x-rays and periodontal probings and other kinds of things which would be considered within the standard of care for what a complete examination is. So if you did something over FaceTime, and FaceTime is a real-time video conference system, so you're looking at a person holding a camera in front of their mouth, you're not going to have the level of detail or the level of information to be able to, I think, in any legitimate way, claim that that's the equivalent to a full examination. So I would refer to that as a problem-focused evaluation, where you've gotten some information, you've focused on the particular problem, you've provided some advice, and as Dr. Sayo said, and certainly in the commercial world in Hawaii now, the major HMSA and HDS, they are covering those as problem-focused evaluations. I wouldn't call it an examination, and it might be at some point in the future where the person can actually come into the office either because they have an emergency that needs to be seen now, where you might actually take some x-rays. Then you might elevate it in terms of how you code it, or later on after the emergency is over and you can see people for a full collection of x-rays and a full charting and periodontal probing, or have your hygienist do that at a distance. But when you have a full set of records and the dentist can evaluate, that's what I would call an examination in terms of meeting the definition that's in the CDT codes for the difference between an examination and a problem-focused evaluation. And I don't know, Dr. Say, if you want to add anything to that.
I completely agree with you. I mean, when we look at teledentistry reimbursements for comprehensive examinations and things like that, it's usually associated with the virtual dental home or telehealth connected teams where we have sufficient information in order to do a diagnosis, treatment plan based upon the records at hand, such as radiographs and photographs. So I completely agree.
Excellent. Well, that concludes the questions that have been submitted. I just want to extend a huge mahalo to Dr. Glassman and Dr. Sayo for joining us today. And thank you for your time and your wisdom. The recording of this whole webinar will be on the a link on the HiFi, as well as the Hawaii Oral Health Coalition website. Thank you so much for your time, everyone. We appreciate it.
Great. Thank you for hosting, and stay safe to everybody.
Thank you, everyone.